بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا ومرحبا بكم في اللقاء العلمي الثاني لأطباء الأنف والأذن والحنجرة سكند لايف فيرتشوال CME ويبينار ضمن فعاليات الفيرتشوال ميتينجز لشركة فاركو فارماسيوتيكالز. أنا معاكم محمود ريحان، برودكت مانجر فاركو فارماسيوتيكال. في البداية أحب أتوجه لحضراتكم برسالة شكر وعرفان لكل أطباء مصر على الجهد والتضحيات اللي بتبذل وفي طبعا إنقاذ شعبنا الحبيب شعب مصر من وباء الكوفيد 19. وأدعو ربنا سبحانه وتعالى إن هو يعني يحفظكم ويجنبكم كل مكروه وسوء. كما يعني النهارده يعني يشرفنا وجود النهارده معانا قامه وعلامه من علامات الانف والاذن والحنجره، مش بس في مصر ولا الشرق الاوسط، على مستوى العالم. ان شاء الله يكون معانا النهارده الاستاذ الدكتور محمد حساب، استاذ الانف والاذن والحنجره بطب جامعه اسكندريه. ولكن حابب في البدايه ارحب بدكتور عطيه زيدان، سيلز دايركتور فاركو فارماسيوتيكالز.
شكرا يا محمود. السلام عليكم ورحمة الله وبركاته. الحضور الكريم، أنا عطية زيدان، سيلز دايركتور فاركو فارماسيوتيكالز. في الأول اسمحوا لي أرحب بالأستاذ الدكتور محمد حساب، بروفيسور أوف أوتو راينو لارنجولوجي in Alexandria Faculty of Medicine. وارحب بحضراتكم تشرفنا في الحضور لهذا الفيرتشوال ويبينار بعنوان An Update on Management of Allergic Fungal Rhinosinusitis. في البداية اسمحوا لي أني أتقدم بأسمى معاني الشكر والتقدير لحضراتكم. وزي ما كنا بنتكلم مع دكتور محمد من شوية، أن حضراتكم على خط النار الأول، يعني التخصص ENT ربنا يسترها عليكم ويلهمكم الميجرز المناسبة لحماية حضراتكم ولحماية الشعب المصري في العمل الدؤوب والمتفاني في مواجهة كوفيد 19 بانديميك، إلى أن نصل بإذن الله إلى بر الأمان. في الحقيقة هذا التجمع العلمي رفيع المستوى ما هو إلا مثال على التعاون المثمر المستمر ما بين شركة فاركو للأدوية وما بين الميديكال كوميونتي والإي ان تي كوميونتي في مصر. في الحقيقة فاركو Pharmaceuticals is the mother company of Pharco Group, founded by Dr. Hassan Abbas Helmi in 1983. 8 healthcare companies are operating in the pharmaceutical field for development, manufacturing, marketing, distributing, and exporting of a comprehensive array of generics and branded generics drug under the name of Pharco, along with a rising number of licensed pharmaceutical products. Pharco is the largest manufacturer of pharmaceuticals in the MENA region, focused on research, formulation, manufacturing, and the commercialization of pharmaceutical products. Today, Pharco employs over 8,000 employees and has over 750 million packs produced in 2019, ranked as a leader in the Egyptian pharmaceutical market. Pharco also exports to above 50 countries around the world. Pharco works toward one goal, which is to provide highly effective and safe pharmaceutical products to patients at an affordable price. Finally, let me show you the chairman message to you, which is, as the largest manufacturer in Egypt, we have a duty toward providing safe and effective pharmaceutical products that are within every patient reach. بشكر حضراتكم وأتمنى لكم ويبينار موفق وعلم نافع من الأستاذ الدكتور محمد حساب.
بسم الله الرحمن الرحيم. مساء الخير على الزملاء جميعا والأعزاء اللي انضموا لنا في الويبينار دهوت. وقبل الحقيقة ما ابتدي أنا بشكر فاركو جروب for sponsoring this event. بشكر الدكتور محمود ريحان، بشكر الدكتور عطية، بشكر الدكتور محمد عبد القادر، كل الزملاء الحقيقة من فاركو دايما interacting مع ال ENT doctors، وبنحاول ان احنا ننظم continuous medical education activity في مجالات اعتقد ان هي تهم كل ال ENT doctors. الحقيقه الموضوع اللي انا هتكلم عليه النهارده اللي هو الالرجيك فانجل راينوساينوسايتس، موضوع very interesting وتشالنجينج. مرض الحقيقه احنا بنشوفه وفي نقاط عديده مثيره للاهتمام، وارجو ان انا هيبقى عندي الفرصه ان انا اعيد معاكم النقاط المهمه في التعامل مع المرض دهوت، وقد برضو اقدر اقول لكم عن خبرتي الشخصيه للواحد على مدى 30 سنه من التعامل مع المرضى بالالرجيك فانجل راينوساينوسايتس. استخلص بعض الخبرات اعتقد ممكن ان هي تبقى مفيده للشباب في التعامل مع نفس المرض. لما بنتكلم على الالرجيك فانجل راينوساينوسايتس، السكرين فروزن عندي يا معتز، ممكن زي ما انا قلت الالرجيك فانجل راينوساينوسايتس مرض عمره قصير نسبيا. ما كناش نعرف حاجه اسمها allergic fungal rhinosinusitis غير يمكن في بدايه الثمانينات او منتصف الثمانينات، وبالتالي احنا النهارده بنتكلم على حوالي 50 سنه فقط لما ابتدى في وعي بوجود هذا المرض او increased awareness. واعتقد في ناس بتشخصه النهارده اكتر كتير قوي عن ما كان بيتشخص من 10 سنين او من 20 سنه فاتوا. زي ما انا قلت يمكن نقطه تاريخيه ان المرض دهوت لما اتوصف في السبعينات او في بدايه الثمانينات كان موجود في الليترتشر بتاع الشيست اكتر من الانف والاذن، لما كان عندهم في الشيست مرض معروف اسمه allergic bronchopulmonary aspergillosis. توجد ان في المرض دهوت في نظير يشبه له بيجي بيأفكت الابر ريسبيراتوري تراكت بالتحديد في البارانيزال ساينسز. الترم نفسه الالرجيك فانجل راينوساينوسايتس اتوصف ب وان راينولوجيست اللي هو روبسون، كان الكلام ده في اوائل الثمانينات. لما بنيجي نتكلم على الالرجيك فانجل راينوساينوسايتس انا قلت في حاجات يعني احنا عارفينها النهارده. ايه الحاجات المهمه اللي لازم نعرفها لما نيجي نتعامل مع الالرجيك فانجل راينوساينوسايتس؟ ان هو بيمثل الغالبيه من حالات الالتهابات الفطريه في الجيوب الانفيه. احنا عارفين ان النهارده في مجموعه كبيره من التهابات الجيوب الانفيه بنسميها التهابات الجيوب الانفيه الفطريه. الفانجل راينوساينوسايتس ده لفظ او مجموعه كبيره بيدخل تحتيها الانفيزيف والنون انفيزيف. النون انفيزيف بنرجع نقسمه الى فانجل بول والالرجيك فانجل راينوساينوسايتس. لو احنا بنتكلم على الكومنست فورم of fungal rhinosinusitis، اكتر نوع من الالتهابات الفطريه اللي احنا بنقابلها هو الالرجيك فانجل راينوساينوسايتس. فدوت طبعا بيمثل عدد لا بأس به من المرضى. النقطة الثانية بالنسبة للالرجيك فانجل راينوساينوسايتس اللي هي بعتقد برضو very interesting، يعني مثيرة للاهتمام، إن الألرجيك فانجل راينوسينوسايتس ده له توزيع جغرافي ومناخي معين. يعني إن الألرجيك فانجل راينوسينوسايتس موجود في الأماكن اللي تتميز بالحرارة وبالرطوبة، ونادر الحدوث في الأماكن اللي الجو فيها بارد، وبالتالي في شمال أوروبا أو شمال أمريكا وكندا نادر جدا تشوف الألرجيك فانجل راينوسينوسايتس. ويمكن الزملاء اللي في أوروبا لما تيجي تتكلم معاهم على الألرجيك فانجل راينوسينوسايتس أعداد الحالات محدودة قوي. العكس تماما في منطقة الشرق الأوسط، منطقة الخليج، الولايات المتحدة الأمريكية في الجنوب، والأماكن اللي هي حوالين خليج المكسيك، عدد الحالات الألرجيك فانجل راينوسينوسايتس نسبيا عالي، وأكتر أماكن تقدر تشوف فيها المرض ده هو. وبالتالي احنا عارفين ان المناخ بيلعب دور، وغالبا برضو الاماكن ديت بتتميز بان حاجه احنا بنقول عليها الفانجل لود. الفانجل لود فانجس او الفانجل هايفي بنقول عليه يوبيكيوس يعني موجود في كل مكان حوالينا، موجود على ايدي، موجود على المكتب، موجود على الكمبيوتر. بس هناك اماكن بيبقى الفانجل لود عالي، وبالذات السبيشيز اللي احنا بنقول الديماتيشيوس فانجاي، البايبولاريس، الالترنيريا، اللي هي اتوجد ان هي اكتر فانجاي انفولفد في الباثوجينيسيس بتاع الالرجيك فانجل راينوسينوسايتس. برضو بنرجع نقول ان الفانجل لود بيختلف بمعنى الشقه بتاعتي، المكان اللي انا فيه لو فيه رطوبه عاليه اتوقع ان الفانجل لود يبقى عالي. الفانجل لود بيبقى عالي في الاماكن اللي هي فيها زرع زي الجناين، الاماكن اللي فيها حيوانات زي الاسطبلات الخيل، المزارع وهكذا. وبالتالي مؤكد الفانجل لود دوت ليه يد في الانسيدنس او البريفالنس اوف ذيس ديزيز في اماكن اكتر من غيرها. وده الكلام ده قد يكون له اهميه ان احنا لما بنيجي نتكلم مع المرضى اللي عندهم الرجيك فانجل راينوسينوسايتس بنحاول ان احنا نعرف برضو الناس ديت البيت بتاعه هل هو فيه زرع، هل هو رطب، هل هو بيدخله شمس، هل هو بيروح يلعب رياضة في أماكن، في جناين، في نادي. الكلام ده كله برضو بنحطه في الاعتبار لما بنتعامل مع مريض الألرجيك فانجل راينوسينوسايتس. حاضر. Moving on to the clinical presentation of a patient with allergic fungal rhinosinusitis. We have to know that the patient who suffers from allergic fungal rhinosinusitis has a very typical profile. What is this typical profile? This is a disease which affects adolescents and young adults. When we are talking of allergic fungal rhinosinusitis, we don't see it in elderly patients. We see it in youngsters, sometimes even in young children, 5 or 6 or 7 years old. The other typical feature of a patient with this disease is atopy. When you encounter a patient with allergic fungal rhinosinusitis and interrogate him about atopic conditions such as allergic rhinitis, such as asthma or atopic dermatitis, you'll find that you're dealing with an atopic patient. So typically a patient with allergic fungal rhinosinusitis is an adolescent or a young adult having history of atopy. Why do these patients come and meet us in our office? Usually these patients are coming mostly coming with their parents and the parent is saying, doctor, this son of mine or my daughter is having problem with her nose all the time. She's either having a blocked nose or blowing her nose. She's not at all using her nose. This is just a non-specific complaint that you can encounter with any other disease. But sometimes we don't get the patients coming to our office on their own, but actually some of these patients get eye problems such as proptosis or epiphora, occasionally diplopia, and the first doctor they go and see is an ophthalmologist. And the ophthalmologist, after evaluation and probably performing a CT scan, we would refer them to ENT doctor. So the complaints are not really very specific. These are non-specific complaints, but what I need to point is that many of these patients come with eye symptoms, as I mentioned, proptosis or diplopia. When we examine these patients, what we usually find is that these patients are having nasal polyps. Sometimes, or in many cases, they are unilateral, but sometimes they are bilateral. What is very helpful if you find, sometimes you can find secretions in the nose, and when you use your suction to drain them out, you'll find that they are very, very sticky and rubbery secretions. And at this point, if you ask the patient, do you get these secretions out? He would tell you, yes, I'm getting sometimes very strange looking secretions. Sometimes they are brownish, sometimes even blackish, and they are very like gum or very sticky and rubbery. At this point, it's very important to send the patient for a CT. So if you're having an atopic youngster with unilateral or bilateral polyposis, it's very important to start thinking of allergic fungal rhinosinusitis. And at this point, as I mentioned, it's very important to send the patient for a CT scan. So I'll just go through some examples. So this is, again, a youngster who was coming because of a little bit of proptosis in the left eye. He's having left nasal obstruction. And on CT scan, you can almost immediately get the typical appearance of allergic fungal rhinosinusitis. What is this typical appearance? First, you'll find that there is multiple sinus involvement. So here you can see the ethmoids, the maxillary and the nasal cavity are opacified. And what is even more important than the opacity is that you'll see what we call this appearance, we call mottled appearance. What does that mean, mottled appearance? It means that you will find that the opacity in some areas show hyperdensity or increased attenuation, and in other areas diminished density. So it appears like a variegated appearance or a mottled appearance, areas of increased opacity or hyperattenuation alternating with areas of hypoattenuation. This is the second important point. The first, as I mentioned, the multiple sinus affections. And when you go to the bony window, here you'll see the very interesting finding where you'll find that there are bony erosions. And here the entire ethmoidal roof and cribriform plate are eroded. But you can see that the soft tissue protruding intracranial is very much well demarcated. It's not irregular. Again, the medial orbital wall shows similar erosion. And these erosions are very much encountered in many of the patients with allergic fungal rhinosinusitis. Doesn't mean that this is a malignancy. So if we put the information together, okay. As I mentioned, another example of a patient with allergic fungal rhinosinusitis, what are the typical findings? First, a youngster. This patient had a very marked allergic rhinitis. She's giving history of nasal complaint. She had prior surgery. If you see here, this is a scar of an external ethmoidectomy. And looking on her CT scan, we can see the surgical defect of the prior surgery. We can see the opacification in the ethmoids and in the maxillary. And again, what is very important, there is this area of mottled appearance where there is area of increased density in the center of the sinus and lesser density around. Again, very similar in the ethmoids, what we are talking about. And again, this deformation of the medial orbital wall. So this is the typical presentations of patients with allergic rhinosinusitis. Sometimes you get a patient who's coming in, a youngster with, again, nasal complaint, and he already had his CT scan done. And when you look on the CT scan, you'll see this opacity in the sinus, multiple sinus opacity, and there is erosion in the ethmoidal roof, but you don't see the mottled appearance. You have to check what is the setting of the window in such a situation. You can go back to the imaging study and get the soft tissue window. When you do the soft tissue window, you'll be able to see this typical mottled appearance. So whenever you're not sure whether this is a case of allergic fungal rhinosinusitis or not, check on the soft tissue window for the this appearance of increased areas of increased density alternating with areas of decreased density. Again, of course, this was an 18-year-old patient, and this is a typical age, typical CT scan. So all the findings are pointing towards allergic fungal rhinosinusitis. Occasionally, we may resort to an MRI when we are not sure of the diagnosis, especially when there is erosion involving the skull base and involving the medial orbital wall. What would we see on an MRI? So this was actually a 7-year-old child that I got referred to me from Aswan. The child had proptosis, and this was his CT scan study. As you can see, there is here the increased density in the ethmoid, and in other areas there is decreased density in the periphery, in the maxillary, increased density in the center. There is deformation of the medial orbital wall. When you request an MRI in these cases, and you get this appearance where there is diminished signal intensity, almost signal void, blackish areas. This is very typical of allergic fungal rhinosinusitis. So on MRI, whenever you get diminished signal intensity, this confirms the diagnosis of allergic fungal rhinosinusitis. Maybe the MRI, besides confirming the diagnosis, it has another value. It can tell you or can show you the interface between the inflammatory process in the sinuses and the periorbita, as well as the dura, because in some cases, the question of invasive fungal disease or a malignant neoplastic process is raised. So sometimes we resort to the MRI to confirm the diagnosis of allergic fungal rhinosinusitis. Coming to the another aspect of the diagnostic handling of these patients, it's quite helpful to request a complete blood count. And in a complete blood count, which is, I think, a very basic blood test, you can tell that there is increase in the number of eosinophils. Again, in these patients, it may be worth requesting the total IgE. You'll find that in these patients, the total IgE is very much elevated, and some people would use it as an indicator of recurrence of the disease or a flaring up of the disease. Again, it would be something worthwhile requesting RAS for fungi. Rust radioallergen sorbent test, which is an in vitro allergy testing. If you request the panel for fungi, you'll find that many of these patients show allergy to different fungal species. So these are some of the basic investigations that are very helpful in assessing the patient coming with a possible diagnosis of allergic fungal rhinosinusitis. Again, if you go back and look in the literature, you'll find that the number of cases reported from one study or another may vary, the information may vary, and that's why Bent and Kuhn back in 1994 have put a number of criteria that are requested to be fulfilled if you are talking about allergic fungal rhinosinusitis. So if you are reporting patients with allergic fungal rhinosinusitis, you have to comply with these criteria. What are these? As I already mentioned, the patient should be a youngster and with history of atopy. The presence of polyps, whether unilateral or bilateral, is another prerequisite. The presence of these brownish or yellowish rubbery secretions that we call eosinophilic mucin is another prerequisite. The CT scan picture I talked about, the increased total and fungal specific IgE. The last thing is that if you take some of these secretions and send for a smear and get it stained by a fungal stain, it should be positive for fungi. So these are the important criteria. In addition, whenever we operate, we should send the sinus contents and ask the pathologist to use fungal stains and again send the tissues and make sure that there are no fungi present within the tissues. So it's very important to make sure that the tissues are not having fungus within invading into the tissues, but rather in allergic fungal rhinosinusitis, the fungal hyphae are present only in the lumen. Now I'll try to simplify very much. How does this disease arise? I think this is a very difficult question to answer since it was described back 35 or 40 years or 50 years ago. There have been a lot of debate on how does allergic fungal rhinosinusitis develops. And if I would summarize the theories up to this point in time, there is no definite theory that's 100% accepted. Still, the debate is going on. But if I would summarize the two main concepts that are being proposed as causes for this disease, the first points that the allergic fungal rhinosinusitis, it is an allergic process. It's a type 1, type 3 hypersensitivity reactions, IgE mediated. And there are a lot of evidence actually that favors this theory. However, another group of workers believe it's not an IgE mediated process at all. It is an immunologic dysfunction caused by the presence of fungal hyphae within the sinus lumen. And this was actually proposed by Jens Ponico from the Mayo Clinic back in 1995. And he has his own arguments that he puts forward when we're talking about the pathogenesis of allergic fungal rhinosinusitis. Regardless, these two opinions, the inflammatory process in allergic fungal rhinosinusitis is driven by the presence of the so-called eosinophilic mucin inside the sinus cavity. As I already mentioned, these people or the patient with allergic fungal rhinosinusitis, they have this thick rubbery secretion, and this thick rubbery secretion we already label as eosinophilic mucin. Whenever this eosinophilic mucin gets trapped in the sinus cavities, the inflammatory process starts. But before going further in the description of the inflammatory process, let's have a look on what is the components of this eosinophilic mucin. The components are actually laminated mucinous fibers, and what is striking is the presence of these clumps or aggregates, abundance of eosinophils, a lot of eosinophils. That's why we know how it's called eosinophilic mucin. Contains a lot of mucin, contains a lot of eosinophils and their degradation products. We know that the eosinophils, when they break down, they release inflammatory mediators as well as charcot-laden crystals. So when we look on the eosinophilic mucin under the microscope, we can tell the presence of these aggregates of eosinophils, the mucin, and the degradation products. If we use fungal stains, we don't see hyphae now. In this cut, we don't see hyphae. If we want to see the hyphae, we need to use fungal stains and keep on searching for the fungus. Here we can see the fungal hyphae when we used silver stain and used higher magnification. That's why when you send the eosinophilic mucin or the sinus contents in a patient that you operated upon, you need to alert the pathologist. First, he needs to use fungal stain. The second important thing, tell him that you should expect that there are fungal hyphae, but they are not abundant. They are very few, and he needs to do some searching under the microscope until he comes up with these fungal hyphae. So if you don't do so, or if the pathologist uses only the H&E stain, probably he will miss the diagnosis of allergic fungal rhinosinusitis, and he will probably tell you there is an eosinophilic reaction or eosinophilic clumps in the aggregates you already sent. Coming back to how does the inflammation goes, as I already mentioned, when the patient starts getting the eosinophilic mucin retained in the sinuses, eosinophilic mucin is toxic, very irritant to the mucosa of the sinus. So once it is retained, it will induce very intense inflammation of the sinus mucosa. Once the sinus mucosa is inflamed, it will swell and gets more eosinophilic mucin produced. The swelling of the mucosa will lead to compromise or obstruction of the drainage pathways of the sinuses. And if you get the sinus drainage pathways blocked, the mucus will be further retained and we will get a vicious circle going on. I need you to remember always this vicious circle of retention, obstruction, inflammation, stasis, and so on. So this, the patient, as a result of this, if we go back to this picture, he ends up with a vicious circle of retention of the eosinophilic mucin, inflammation, blockage, and this inflammatory tissue will start to expand. So we're having an expansile inflammatory process in the sinus, and with time, it will press on the bone and will spread into the adjacent, it will erode this bone and spread into the adjacent orbit or the cranial cavity. So this is, in short, how does the inflammatory process proceed. Sometimes the diagnosis, and actually we get to see these patients, especially patients getting bilateral polypi with allergic fungal rhinosinusitis, whenever these patients come to the outpatient, and many of the doctors would see these patients, they would see the polypi in both nasal cavities. They think of these cases as cases of diffuse sinonasal polyposis. Diffuse sinonasal polyposis is another variant of chronic rhinosinusitis with polypi, different from allergic fungal rhinosinusitis. And if they think that it is a case of diffuse sinonasal polyposis, they may give this patient some corticosteroid, whether topical or systemic, and we tell him you have to live with it because even if we operate, maybe it will come back. And so in some instances, there is overlooking of the diagnosis. My advice here is that whenever you're getting a patient with bilateral nasal polypi, even if you think that it's a diffuse sinonasal polyposis, please ask this patient to go for a CT scan, because some of these patients will have actually this typical allergic fungal rhinosinusitis. And in these patients, as we will get to say in a moment, surgery is absolute indication. While in diffuse sinonasal polyposis, maybe if you give to the patient medical treatment or conservative treatment, it is accepted. But with allergic fungal rhinosinusitis, surgical treatment is mandatory. Because, as we mentioned, this is an expansile pathology that may spread intracranially, though extradural, or spread intraorbitally. So the moral of the story, whenever you're having a patient with polyposis, whether unilateral or bilateral, it's important to get at least a CT scan. Coming to the treatment of allergic fungal rhinosinusitis, we need to remember the vicious circle. So simply, we need three things to be done. We need to do surgery, we need to give medical treatment, and lastly, these patients require extended endoscopic follow-up, and we will come to this point later on. Talking about surgery, again, surgery for allergic fungal rhinosinusitis, we all now perform endoscopic sinus surgery, but when we are operating on a patient with allergic fungal rhinosinusitis, this is a case that needs certain meticulous approach in order to achieve what we intend. So whenever we're having multiple sinuses affection, all the diseased sinuses should be managed. All the allergic mucin, which is inspissated, sometimes it's inspissated in narrow crevices, inspissated in air cells, in hidden areas. We need all the time, our aim at the time of surgery is to bring all the allergic mucin out. If there are polyps, granulation, or cetic bone, all this should be taken care of, and we have to ensure that the sinuses are widely open, widely marsupialized. I always tell my residents whenever I'm operating on a patient with allergic fungal rhinosinusitis, I'm as if operating on a patient with a primary acquired cholesteatoma. You have to bring all the cholesteatoma out. You have to have a widely suturized cavity in order to avoid recurrence. And maybe I'll show you this video clip of the child coming from Aswan. He was already, I mentioned, he's about 6 or 7 years. He had proptosis, and here we are taking out the uncinate process. You can see that, we can tell that these cases usually bleed, or the bleeding is relatively excessive. And in order to minimize the bleeding, you should prepare the patient preoperatively with a systemic steroid. As you can see here, once we have taken the polyps out, the uncinate out, we are getting to see these inspissated eosinophilic mucin, and in this case, they are quite hard. They are not soft, and the best way to bring them out is to keep on irrigating. And then here I'm trying to squeeze them out of the sinus cavity. As I already mentioned, this is an allergic fungal rhinosinusitis. The disease is within the sinus lumen. The sinus mucosa is more or less healthy, and it's the good barrier whenever there is bony erosion. So we are doing our best to bring bluntly these concretions out. Takes, of course, this is an edited video. It takes a while, and with blunt spoon, we're just establishing a plane between the normal mucosa and the fungal concretion, and then pushing them away from the mucosa and then bringing them out whether with a blunt instrument or with a forceps or with irrigation. And this process can take, it may be time consuming, but with time you'll be able to establish more and more anatomical landmarks. And here you'll see we're pushing out these concretions. And once we are done, we're starting to see the medial orbital wall. And this is the posterior ethmoid with the concretions inspissated. And bringing them out again, we'll be able to see more and more landmarks. Now, this is the posterior ethmoid, and this is the superior turbinate. And we know that we're in the posterior ethmoid. The maxillary has been cleared, medial orbital wall. Now with the 30 degree, we can see this was a 7-year-old child, a small frontal sinus. So all the involved sinuses should be cleared, all the eosinophilic mucin brought out. This is a must if you want lasting result. Another case, again with allergic fungal rhinosinusitis, and we're removing the polyp there, and in a moment we will be getting into the ethmoid. Sorry. Here we can see the eosinophilic mucin is softer than the previous case, and we're seeing here that we're able to again dislodge this eosinophilic mucin off from the middle turbinate, and we are preserving the mucous membrane, and we are widely opening the ethmoids. When we are doing our surgery, you should always put in mind that you need to follow up these patients post-operatively, so the wider you marsupialize your cavity, the better. And if you have achieved the what I already talked about, you'll get very good post-operative result, as in this situation. You can see a very widely opened cavity, clear maxillary sinus, medial orbital wall, posterior ethmoids, the skull base. So this is the kind of cavity that we would like to see after surgery for fungal rhinosinusitis. Why? Because the more you aerate and ventilate the cavity, the better is the outcome. And in a moment, I have to tell you that another distinct feature of a patient with allergic fungal rhinosinusitis is that this disease is called a recalcitrant disease. In other words, there is a high recurrence rate. And this is what you have to talk to the patient about whenever you're coming to manage this patient. This patient should know that his disease is not taken care of only by surgery. And if this patient doesn't abide by the other measures we will talk about, which is the extended follow-up and the continuous medical treatment, he's very prone to get repeated surgery. So it's very important to discuss this with the patient. And whenever you're doing good surgery, the chances of recurrence are much less. So this is something that you need to discuss with the patient. And here I'm telling you again that the commonest cause of early recurrence is inadequate or incomplete surgery. So it doesn't mean that when we're doing an endoscopic surgery, it means that it's a limited surgery. No, you need to widely open the cavity, remove all the polyps, remove all the eosinophilic mucin, make sure that there are no residual bony partitions or narrow antrostomy. These are the things that may help the stages of mucus and lead to early recurrence. Again, the second component of our strategy, I talked about the surgery. The second is the medical treatment. The patient should know that even if after he had a good surgery, he needs to keep on using medications to control his allergic or atopic state to prevent or delay the recurrence of the disease. And if we talk about what are the medications that we usually use, of course, a lot of medications have been proposed, but this publication by a big group of rhinologists, including Amin Jaber from Vancouver, Canada, he had studied or did a meta-analysis of different studies and coming up with evidence-based recommendations. So based on the recommendations, and actually this is what we also believe in, the medical treatment, the most important medications are the systemic steroids. What kind of, or what form of systemic steroids we are using? We are using oral corticosteroids in short bursts. Whenever the patient is going to surgery, we are preparing him preoperatively and the time of surgery and in the early postoperative period with systemic steroids. Again, whenever the patient is having a flare-up or a viral upper respiratory tract infection, in many instances, we need to control or stabilize the mucosa by giving a short burst of systemic steroid. In addition, topical steroids, of course, are very important. The sprays have been the standard of care for patients with allergic rhinosinusitis. We use them indefinitely. The problem with the sprays is that they are good medications, or they reach only the nasal cavity whenever the patient are using them. They don't get to reach into the sinuses. That's why we know nowadays is that irrigations, saline irrigations in a squeeze bottle, this gives you a positive pressure and a big volume that it irrigates better the paranasal sinuses. And if you put in this saline medications, they will deliver them in higher concentration to the sinus cavity. And now, of course, we have been using the Pulmicort. This is an off-shelf, off-label use of the Pulmicort as a medicine to be put in the irrigation, and this really have made a big difference. Though until now there are few publications in this respect, but I think in the near future more and more publication will confirm the positive role of the Pulmicort. So if I would concisely talk about the medications, these are the systemic steroids used intermittently. The topical steroids, they are used indefinitely. The oral antifungals, there are again the leukotriene modulators. The topical antifungals, again, there is no sufficient evidence to warrant their use in these patients, and sometimes occasionally they are proposed by some workers, but again, up to this moment in time, we don't have enough evidence. The immunotherapy as a therapeutic line has been proposed by some immunologists, especially Richard Mabry and his group in Dallas, United States, and they claim that by getting the patient to go for immunotherapy, this will reduce the recurrence of the disease. But on the other hand, a lot of other studies did not really show significant benefit from going to immunotherapy. Besides, doing immunotherapy for allergic fungal rhinosinusitis needs a real expert in this modality of treatment. Coming to the last point in breaking the vicious circle is the need for endoscopic follow-up. Whenever I operate on a patient for allergic fungal rhinosinusitis, I keep on telling him, you need to abide and come for follow-ups, even if you're doing well, even if you're having no complaint. And again, whenever these group of patients with allergic fungal rhinosinusitis, at least in my practice, I get to know a lot of details about their life. I get them as young as 6 or 7 or 20 or 18 years old, and I know that they went to which university. I know when they they got engaged. I know when they got married. That's because they keep on coming back and forth. And this is what you need to do with these patients, because as I already mentioned, these patients, whenever they get an allergic flare-up, the eosinophilic mucin is produced excessively and may get plugged in the sinus cavity. And if you don't catch the patient at this stage and do an office debridement, give the patient a short burst of steroid, the patient can come back after a few months with massive disease. So if you do good extended endoscopic follow-up, this may help many patients not getting recurrent disease or going to the operating theater. Some patients would tell me, I'll keep on coming back and forth for life. Will I keep on using steroids or topical steroids for life? A very interesting point in this disease is that this disease burns out or fades out as the patient ages. So many of the patients I already managed by reaching the late 20s or early 30s, they outgrow their disease, and at this point they don't need this very close follow-up. I think this was my last slide. Just to conclude, I already talked about the diagnostic features for this disease. We're already aware of these points: the adolescent young patient, the polyps, the eosinophilic mucin, the CT scan. These are very important so as not to miss the diagnosis of allergic fungal rhinosinusitis. The second important point I'm leaving you with is the treatment strategy, breaking the vicious circle by surgery, medical treatment, and extended endoscopic follow-up. Thank you very much, and I would be glad to answer any questions.
Thanks, Professor Dr. Muhammad, for the fruitful sessions. You enrich our knowledge as usual. For all valued attendees, you can claim your certificates by pressing the orange button on the banner of the platform and asking about 5 questions questionnaire to receive your certificate by mail. And also you can leave your questions and inquiries in the chat box below the platform. For Dr. Muhammad, I have some questions. Patient complaining of sandy secretions, both nasal and post-nasal.
Can you, patient complaining of what secretions?
Sandy.
Sandy?
Sandy. From sand, desert.
From sand.
Yes.
I'm not sure exactly what would be the cause for this, but on the other hand, if the patient would come in the office, he would tell me I'm having nasal or post-nasal secretions, and these secretions, he's describing them as sandy or giving them any description. I would usually ask the patient, do you see the secretions yourself? Can you show me what you're talking about? Can you spit out the secretions? And of course, getting a detailed history of the patient, the background, is he allergic, not allergic? Is he having reflux or not? Is he getting the secretions from one side or both sides? So all these are very important points for me to be able to come up with an answer. And again, the next step is to take my endoscope and examine both nasal cavities. And by examining both nasal cavities, I'm looking for all the pathological findings that may lead me to the right answer. So if we're talking about allergic fungal rhinosinusitis, if I can see the rubbery secretions in one side, then this may help me. And the patient is a youngster, and the patient is atopic. This would be in favor of allergic fungal rhinosinusitis. If I can see a mass, for example, a necrotic mass, could that be a malignancy? So the next, apart from the history, the endoscopic examination is very important. If I get information from endoscopy, that's fine. If the patient is having this problem for a while, if the condition is significant, I would go or send them for a CT scan. So putting the three together, the history, the endoscopic examination, and the CT scan will probably sort out the diagnosis in this case.
Okay. Thanks, Doctor. Another question. What are the ideal follow-up visits interval for the repeated AFRS?
Again, this is a very good question. How frequent you need to see the patient with allergic fungal rhinosinusitis? What I usually do is that following surgery, I would see the patient once every week or 10 days, tailor my medical treatment to the patient so as to get the good healing in the operative cavity. If the patient needs some debridement in the office, I would do it. If the patient, usually, as I already explained, usually the patient is put on oral steroid as well as saline irrigations. So with time, as the mucosa health heals and the cavity heals, I usually start tapering my steroid. This usually takes about 2 to 3 weeks after surgery. So once I reach a well-healed operative cavity, I usually put the patient on topical medication, topical irrigation with Pulmicort or steroid spray, and I would start expanding or extending the period between the office visits. So sometimes I see the patient once every month during the first year, and maybe if the case is going well and the cavity looks stable, I would expand the periods or the office visits once every 2 months, and vice versa. If the patient is having an angry-looking cavity, edematous areas, or if the patient gets an upper respiratory tract infection, maybe I would ask the patient to come back earlier to be able to manage the patient with medical treatment and maybe some office debridement until, again, the cavity heals nicely and the mucosa is stable. So, in short, how frequent I need to see the patient, this is very much governed by the endoscopic appearance of the operative cavity, not by the patient's subjective feeling, because sometimes the patient is doing well, or he's feeling well, but when you examine him endoscopically, the cavity is not a silent one or a calm one. So I decide upon the frequency based upon the endoscopic appearance.
Okay, thanks, Doctor. Another question: any rule for biologic treatments post-operative?
Biologics, yes. Okay. Well, recently some centers or some rhinologists have been implementing the biologics in managing patients with allergic fungal rhinosinusitis. Again, there is, up to this point, these are anecdotal reports. They are not based on randomized controlled trials. There is no enough scientific evidence to justify their use in patients with allergic fungal rhinosinusitis. But on the other hand, we now know that we are using the biologics in patients with aspirin-exacerbated respiratory disease, in patients with intractable or massive polyposis. So I think that in the coming few years, we will see more and more of these biologics used in some of the resistant cases with allergic fungal rhinosinusitis. But we have to put in mind that up to this moment, besides the problem of their being very expensive, there is no enough scientific evidence to support their use on wide scale in patients with allergic fungal rhinosinusitis.
Okay. Dr. Hisham Al-Badan thanks you, Professor Dr. Muhammad Hassab, and asks you, is there any urgency in operating on a patient with AFS in this era of COVID outbreak?
First, I thank Dr. Hisham for joining us tonight, and we really miss him here in Alexandria. He's a colleague and eminent surgeon in our department in Alexandria. I wish him best of luck in Saudi Arabia. And he's asking a very valid and important question. Is there urgency to operate on a patient with allergic fungal rhinosinusitis in the current situation of the COVID-19 disease? I struggle with myself because I'm actually having several patients waiting for that surgery, Hasham. I think if it is a mild disease with no erosions, and it's just the problems of the blockage of the nose and so on, maybe giving the patient short bursts of systemic steroid, you can buy time until the time is appropriate for operating on these patients. On the other hand, I need to tell you that some of the patients, especially those with posterior ethmoids, well-pneumatized posterior ethmoids, well-pneumatized onodi cells, well-pneumatized sphenoid. It is my experience is that these diseases or these patients are very vulnerable to compression of the optic nerve and the carotid artery by the expansite pathology in their sinuses. And actually, I have another talk on the allergic fungal rhinosinusitis where I'm showing some cases of patients with well-pneumatized sphenoid or onodi cell and posterior ethmoid with massive fungal rhinosinusitis, where the patient lost vision in one eye in two patients. I have two patients, two female patients. One totally lost her vision in her right eye. The left eye was almost very low visual acuity. And what was there is that the optic nerve was markedly compressed on both sides and because of her allergic fungal rhinosinusitis disease. So I think if you're having significant erosions in a patient with allergic fungal rhinosinusitis, if the patient is coming with compromised vision, if the patient is coming with headache, because some of these patients, the disease has extended intracranial and is elevating the dura, stretching the nerves. These are serious cases. These, I think it is justified to get these patients to be operated upon at your earliest convenience, and you should start systemic steroid at your earliest convenience in order to save the compromised vision or the compromised optic nerve and save the patient from any further neurologic complication. So again, you have to use your judgment whenever you feel that it is a massive disease, I don't think there is any problem in operating on these patients, putting on your proper personal protective equipment. If you can get a PCR 24 hours prior to the surgery, again, these are the standard procedures that we should do when we are operating in the COVID era.
Question from Turkey. Is there any role for Sinopret in management? I think Sinopret is a medication.
Sinopret is a herbal medicine. I think it is very popular in Germany and in some areas. Unfortunately, it is just a herbal medicine. It doesn't really, there are no studies or any supportive literature that justifies its use in this situation where we're having expansile erosive pathology. So if it is an adjunct treatment or an add-on treatment, but it's not a main treatment, as I already highlighted, the main treatment in allergic fungal rhinosinusitis, essentially you need to do surgery to clear out, to restore the ventilation, clear out the eosinophilic mucin, diminish the allergenic irritation, allergenic stimulation. Number 4, open the way for irrigations with medication. So these are the merits of operating on a patient with allergic fungal rhinosinusitis. So this is the main step to be performed initially, together with the medical treatment, which uses systemic, short bursts of systemic steroid and long-term topical steroid. Any other medication would be just an add-on.
Dr. Mustafa Abdel Mahmoud asks you, Doctor, about allergic fungal rhinosinusitis in diabetic patient.
This is again very important question. If the patient is diabetic, of course, this makes things a little bit difficult, because it will restrict our use of systemic steroid. So if you think that, again, we will follow the same algorithms in terms, you'll do surgery, you'll do post-operative medical treatment, and if you feel that this patient is in need of systemic steroid, again, what I usually do is that I would write down the prescription for the systemic steroid I need this patient to take, and I would send him to his diabetes doctor to either modify the treatment for diabetes, plus or minus modifying the systemic steroid medication. Again, in these patients, I would rely more on the topical steroid, especially the pulmicort irrigations, because even with the pulmicort irrigations, it has been shown that it doesn't, the systemic absorption is not significant. So if the case would come under control with the topical sprays or the topical saline irrigation with pulmicort, that's fine. If I need to give a systemic steroid, then I will just go ahead. I wouldn't hesitate to give the systemic steroid, provided that this is monitored by the diabetes doctor.
Okay. Dr. Muhammad, I know you are very tired, but I beg you for replying only on 2 questions only.
Okay.
Rule of systemic antifungal.
Okay. Very good question. Some people have been using systemic antifungals, especially the iconazole group, in patients with allergic fungal rhinosinusitis. Again, when I personally, I don't use them, except in very few cases when I cannot get good control of the allergic fungal rhinosinusitis. And here you have, I have to mention, there are no randomized controlled trials that support the use of systemic antifungals. All the published literature doesn't show really great outcome after using the systemic antifungals, though some rhinologists here and there would occasionally use the systemic antifungal medication, the iconazoles, and probably they are relying, or it has been shown that the systemic antifungals, they have an anti-inflammatory effect. So they are not benefiting the patient because of killing the fungus. They are benefiting the patient because they are having an anti-inflammatory effect. But on the other hand, if you use the systemic antifungal in Egypt, you have to always remember that the systemic antifungal are hepatotoxic. So many of the patients in Egypt, they have borderline liver functions. So you have to make sure that the patient is having good liver function. If you will keep on using it beyond 2 or 3 weeks, you have to keep on repeating the liver function tests. The second or the additional point, they are expensive medications. And as I already mentioned, there is no one came up with a study to show that they really made a difference in managing patients with allergic fungal rhinosinusitis. So personally, I'm not a big fan of the systemic or the oral antifungal medications.
Last question. In invasive fungal sinusitis complicated with intracranial complications, surgery is the first choice or medical option?
Okay, so this is a totally different pathology when we're talking about invasive fungal rhinosinusitis with intracranial extension. I think this needs another webinar, Dr. Mahmoud. But I will try to summarize. When we're talking about invasive fungal rhinosinusitis, if I'll break it down, you're having the acute invasive and the chronic or the indolent. The acute invasive, it occurs in an immunocompromised patient, such as a patient with diabetic ketoacidosis, uremia, a patient with leukemia, blood malignancies, bone marrow suppression, and this runs a very aggressive course. So if you're going to do any surgery, or the initial, or the always think of these patients, the most important issue in these patients is to try to revert their immune state. So if he's a diabetic ketoacidotic patient, it's very important to improve his diabetic ketoacidosis. If the patient is uremic, you have to get this patient to hemodialysis and try to revert the immunosuppression. It's very difficult in patients with leukemias and bone marrow. Many of these patients go for bone marrow transplant, and sometimes this bone marrow transplant fails. These are the outcome in these patients with leukemias and bone marrow failed transplant. The outcome is not so good as compared to patients with diabetic ketoacidosis and uremic patients. Why? Because in diabetic patients and in uremic patients, you can work on reverting the immune state. But in patients with a failed bone marrow transplant, you cannot really do anything in regards to their immunosuppression. So coming to these patients, you should first, the most important issue is to work on their immune system. The second is to start systemic or intravenous amphotericin B, plus or minus oral antifungals such as the VVAN. The third step is to operate, and here I would operate on early patients and these patients are the patients where you can work on their immune system. And the surgery here would be very much clearance of the necrotic tissue in the nasal cavities, sinuses, maybe in the orbit. But if there is brain involvement, I would stop at this point. I would try in my surgery not to breach the connective tissue barriers, whether the dura or the periorbital, because these two barriers are really helpful in limiting the spread of the disease. And I would rely on the systemic antifungal to take care of the intracranial component of the disease, because by time we learned from previous experience, whenever you expand your surgery in these cases into the brain, the prognosis is really very bad. So we would stop at the dura as much as possible and in our surgery and rely on the medical treatment for these patients. On the other hand, in patients with failed marrow transplant, patients with hematologic malignancy, it's very really, the outcome of surgery in general is not good. We try to rely much on conservative measures and hoping that these patients will get better. If we are obliged to operate, then it's very limited surgery. And if you're operating, for example, on a patient with a failed marrow transplant or hematologic malignancy, you have to make sure that the platelet count in these patients is at or about the level of 40,000 platelet. You can transfuse to the patient platelets at the time of doing the debridement in the nasal cavity. Otherwise, you can even get bleeding because, as I already mentioned, these patients, the blood profile is really very much unfavorable. You'll find again that these patients, we have learned that something that tells you about the prognosis of the outcome of management of these patients is the absolute neutrophilic count. Recently, I had a patient who had acute myeloid leukemia, and all the neutrophils in his blood is 22 neutrophil. So this is, and the whole white cell count is about 1,500. And the patient is undergoing chemotherapy, and he developed acute invasive fungal rhinosinusitis. So again, to conclude this expanded discussion, it depends very much the management differs depending upon the cause of the immunosuppression in the patient. Generally speaking, we would not recommend breaching the dura or breaching the periorbital, and rely on the antifungal medications and all other measures to revert the immunosuppression of the patient.
Thanks دكتور. Let me close in Arabic. شكرا دكتور محمد على وقت حضرتك والفروتفول سيشن والانتر اكشن. معلش احنا تعبنا حضرتك كتير النهارده.
لا انا اللي سعيد والله يا دكتور محمود، وبشكر الحضور جميعا، وارجو ان البرزنتيشن والدسكشن ديت تكون افادت البعض. Thank you very much for everyone for their participation. وبشكر فاركو وبشكر the ICOM group for their efforts.
شكرا يا دكتور، ونتمنى للجميع ان شاء الله ان هم يكونوا دايما بخير كده وصحه، وربنا ان شاء الله يحفظهم، ونلتقي بحضراتكم ان شاء الله في ايفنتات قادمه. شكرا بروفيسور دكتور محمد، شكرا للجميع.